This talk on the functional anatomy of the chest should help you understand the why of the structure than only the structure itself. Well, the chest is a conical cavity. It has got an inlet from the neck and an outlet into the abdomen. It has got walls where there are ribs moving in a pump handle or a bucket handle movement, increasing and decreasing the volume of the chest cavity during inspiration and expiration. And it contains the heart and its great vessels. It contains the lungs and the pleura. It contains the mediastinum, which give passage to the esophagus, the aorta, the inferior vena cava, and bilaterally behind the diaphragm, which guards the outlet into the abdomen, you have the passage from center to periphery of the aorta, the psoas, the quadratus lumborum, the sympathetic trunk, the thoracic duct. And this diaphragm would go down, increasing the volume in inspiration, and go up, decreasing the volume of the chest in expiration. And therefore, diaphragm movements are vital to normal breathing. Upper six ribs would rotate on this axis A. This axis A is on the rib joining the vertebral body and the rib joining the transverse process. Rotation on this axis would lead to increase in both the anteroposterior and the transverse diameter of the chest, and it is called as the pump handle movement. Now this movement would always follow the bucket handle movement of the lower six ribs. It occurs in the upper six ribs and it follows the bucket handle movement of the lower six ribs. And this is the bucket handle movement. You see this rib and it is moving like a bucket handle. It is basically moving on this B axis and it is increasing the transverse diameter of the chest. Now, since the lower six ribs must move first and then the upper six ribs will move, so regardless of where the fracture is, if you immobilize the lower six ribs in expiration, then the upper six ribs will become automatically immobilized. Thus, this is the principle of treating fracture rib, which is called as Dale's method of strapping of the lower six ribs in expiration, regardless of where the fracture of the rib is. Then we will talk about if this rib is fractured at two places. Then the intermediate fragment has become flail. It is not moving with the rest of the chest wall. In inspiration, it will be blown out. In inspiration, it will be sucked in. In expiration, it will be blown out. And thus, this is called as the paradoxically moving segment of the chest. Now, because of this paradoxical movement, the pressure changes on the affected side would be less as compared to the opposite side. So less negative pressure on the affected side as compared to the opposite side will make the air move from the affected to the normal side, and less positive pressure on the affected as compared to normal side in expiration will make the air move from the normal to the affected side across the center of the trachea, and this movement is called as pendular air movement or pendeluft, and as it was described by Germans, therefore the German synonym pendeluft signifies it. The third thing about rib movement is that intercostals are supplied by the thoracic nerves, which are paralyzed in spinal cord injuries above T1. Then the breathing is dependent on the phrenic nerve, which is supplied by 3, 4, and 5. And if there is a spinal cord injury above C3, it is incompatible with life. So these are the three things that you have to learn about movements of the rib. See how the intercostals reduce the intercostal space. These intercostals will reduce the intercostal space, and therefore the whole thoracic cage will be lifted up by the pectoralis minor muscle and the scalene muscles which are attached to the first rib in inspiration. And this is causing the pump handle and the bucket handle movement, which will increase the volume inside the chest and suck in air from the atmosphere. The diaphragm, as it contracts, will become less concave and will help in increasing the chest volume during inspiration. Now, in expiration, the innermost intercostals arising from the transverse process of the lower vertebra will depress the ribs or reverse this movement, and by decreasing the thoracic volume will push the inhaled air out. What you see is the thoracic inlet which connects the chest to the neck. Now this thoracic inlet is formed by the vertebra behind and is kidney shaped, and this is the first rib meeting the sternum in front. And let us see what passes through this. So first of all, behind the muscles in the prevertebral fascia coming from the neck are passing through this, and ahead of them is the prevertebral fascia, behind which a cold abscess can collect and narrow the thoracic inlet. Then ahead of it you have the esophagus and the trachea which pass through this. Then the great vessels, the carotid system going into the neck and the subclavian system going into the upper extremity, pass through this, both the arteries and the veins. Then the vagus and the phrenic nerve and the sympathetic trunk go into the chest through this, and the vagus nerve will give a recurrent laryngeal nerve coming into the tracheoesophageal groove and will go into the larynx. So these are the basic structures passing in the center of the thoracic inlet. Now then, the other structures are the cupola of the pleura. Now we'll go into slightly greater detail. Related to the neck of the first rib, you have the lower trunk of the brachial plexus formed by C8 and T1. So here you see the T1 root. Then you see the first intercostal artery and vein, and then you see the sympathetic trunk. Now the sympathetic trunk supplies the sympathetic to the upper limb and the head and neck. Therefore, when blood supply of the upper limb is compromised, then you treat that vascular insufficiency. One of the methods is by blocking this ganglion here, which we call as the stellate ganglion, and which is formed by the inferior cervical ganglion and the first thoracic sympathetic ganglion. Now you put under ultrasound control, you put in botulinum or phenol into this ganglion, and you find out that the sympathetic system is paralyzed, and you are successful by judging the vascularity of the upper limb and also judging the paralysis of the sympathetic supply of the head and neck. The three signs are eye signs and two signs are face signs, and these are the signs called the Horner syndrome. The eye signs are ptosis, meiosis, and enophthalmos. That means the upper lid goes down, the pupil constricts, and the eyeball is inside as compared to the opposite side. The face signs are flushing or reddening, which is called as flax sign, and anhydrosis, that means absence of sweating, which you diagnose by the starch iodine test. So this finishes the structures from the neck of the first rib and how you deal with them. The next we pass the subclavian artery across the first rib, becoming the axillary artery, and we divide the subclavian artery by the scalnus anterior muscle into the first part, the second part behind, and the third part after the scalnus anterior. So before, behind, and after the scalnus anterior muscle. The first part gives the vertebral artery and the internal mammary artery. The second part gives two trunks, which are called as the costocervical and the thyrocervical trunk. The costocervical means first intercostal and ascending cervical, and thyrocervical means inferior thyroid, which rises up the medial border of the scalnus anterior, crosses the carotid sheath, and passes into the tracheoesophageal groove into the thyroid gland, accompanied by the recurrent laryngeal artery. So when you are doing thyroidectomy, you must ligate the inferior thyroid artery lateral to the carotid sheath so that you don't ligate the recurrent laryngeal nerve with it and cause laryngeal paralysis. So this is the inferior thyroid, and then the two other branches of the thyrocervical trunk are thyro, we have covered. So cervical are suprascapular and transverse cervical, which plaster this phrenic nerve onto the scalnus anterior. So this phrenic nerve is a nerve which winds round the scalnus anterior, and that's how you recognize both the scalnus anterior and the phrenic nerve. And they are plastered, the nerve is plastered to the scalnus anterior by the suprascapular and the transverse cervical arteries. So this is behind the scalnus anterior. Also behind the scalnus anterior is the brachial plexus emerging between the anterior and the medius and joining the artery. Now in front of the scalnus anterior is the subclavian vein, which gives connection to the internal and external jugular vein and the vertebral vein. Now, something which is very peculiar is that there is a subclavius muscle here, which is supplied by the nerve to subclavius. Now, this nerve to subclavius gives a branch which passes under the subclavian vein and connects the phrenic nerve. This nerve, this arch of the nerve, which hooks the subclavian vein, is called as the accessory phrenic nerve. So this hook by the accessory phrenic nerve creates stasis and thrombosis of the axillary vein or the subclavian vein. So accessory phrenic nerve is responsible for spontaneous axillary vein thrombosis, which is usually unilateral. Now then you see here is the passage of the thoracic duct, which passes anterior to the scalnus anterior and opens into the subclavian vein. So besides the trachea and the esophagus, this thoracic duct is also passing and entering the subclavian vein here. Finally, in this diagram, you see the thymus gland, which also lies in the thoracic inlet. Now all these structures can get into a entrapment or compression because either the scalnus anterior insertion is increased, which is called as the scalnus anticus syndrome, so that the subclavian artery and the brachial plexus gets compressed, or there is a cervical rib above the first rib. So scalnus anticus syndrome and cervical rib press the blood supply and the nerve supply of the upper limb. The second thing is that there can be a thoracic inlet syndrome where there can be a cold abscess anterior to the vertebra. There can be lymph nodes. There can be swelling from the upper lung areas, and any space occupying lesion in the thoracic inlet will cause congestion of the head and neck, congestion and ischemia of the brain, and ischemia of the upper limb. And this thoracic inlet syndrome has to be diagnosed and decompressed. The diaphragm closes the thoracic outlet. It arises from the median crura. Right and left crura form the median arch from under which emerges the aorta. Then from the right crura and the left crura, there is these tendinous arches which go to the tip of the transverse process. So this is the medial arch, and from the transverse process to the base of the 12th rib, this is the lateral arch. So from the median, under the median arises the aorta, under the medial arises the sympathetic trunk, the iliopsoas, and from the lateral arises the quadratus lumborum muscle. Lateral to the quadratus lumborum attached to the 12th rib is the thoracolumbar fascia. You cut this fascia to enter the space anterior to the psoas and the quadratus lumborum and behind the kidney. Then this thoracolumbar fascia will also give attachment to these muscles which are internal oblique and transversus abdominis. Now this finishes the structures that pass behind the diaphragm. The tendon of the diaphragm as a whole through which passes the inferior vena cava, and the right crura gives the muscular arch around the esophageal hiatus through which passes the esophagus and the anterior right and left vagus nerves. So this in short is about the thoracic outlet. Now we go on to the contents of the chest, and they are the heart and its great vessels, the lungs and the pleura, and the mediastinum between the two lungs, which passes the esophagus, the thoracic duct, the sympathetic trunks, and the vagus and phrenic nerves. It enters the trachea and the great veins. It exits the aorta, and the azygos veins arise and finish in the chest itself. So on the right side, you see that the blood comes from the superior and inferior vena cava, passes through the tricuspid valves into the right ventricle, is pumped from the right ventricle into the pulmonary arteries, into the lungs, gets oxygenated there and returns through the pulmonary veins into the left atrium, passes through the mitral valve into the left ventricle, and is pumped through the aorta into the rest of the body. So this heart basically consists of an endocardium, myocardium, and pericardium. Then what else you see here are these veins and arteries which are supplying the muscle of the heart. This is the arteries and these are the veins. Now the peculiarity about these arteries is that if the heart is contracting during systole, the intermuscular pressure is much higher than the arterial pressure. Therefore, heart will take its blood supply only while it's in diastole, while it's relaxing. And therefore, as the heart rate becomes faster and faster, the systole time cannot reduce, the diastolic time reduces. And after certain rate, the heart starts becoming ischemic because there is not enough time between the two systoles for the heart to take its nutrition or supply. Therefore, you should remember that athletes would die because of a very fast heart rate, and therefore while they are exercising, they should keep a watch on their pulse rates. Notice that the air passage begins from the nose, where air is humidified and temperature controlled. Passing through the nose and the oropharynx, it enters the larynx through the trachea and bronchus into the alveoli, being sucked in by an expanding chest and the lowering diaphragm. The oxygen in the air moves through the alveolar membrane into the blood, oxygenating it, and oxygenated blood returns through the pulmonary veins into the left atrium, left ventricle, and into the body through the arterial system, starting with aorta. CO2 moves from the blood to the alveolar air, and the collapsing chest cavity and rising diaphragm pushes it out through the bronchotracheal system, pharynx, and nose into the atmosphere. Air to the lung is ventilation, blood to the lung is perfusion, and CO2-O2 exchange across the alveolar membrane is diffusion. These three functions of the lung are affected in disease and have to be diagnosed and corrected through medicine. Negative pressure in the pleural membrane plasters the lung to the chest wall and diaphragm and thus cause it to move through the intercostal nerves and the phrenic nerve. Larynx contains the vocal cords, which create turbulence in the exhaled air and thus creating sound, which is called as phonation. By the combined action of the palate, nose, tongue, teeth, and lips, they get converted into words, into sound, and into language. So this is what you learn from this slide. So you now know that air to lung is ventilation, blood to lung is perfusion, and CO2-O2 exchange across the alveolar membrane is diffusion. So this is produced by negative pressure in the pleural membrane, which plasters the lung to the moving chest wall and diaphragm, which is supplied by the intercostal and the phrenic nerves, and that makes this ventilation, perfusion, and diffusion possible because that is responsible for inspiration and expiration. So now if we fill fluid or air in the pleural space, fluid, hydrothorax, blood, hemothorax, pus, empyema, air, pneumothorax. And the pneumothorax can be open, air can go in and out of the pleural cavity. Close, can neither go in nor come out, or tension. That means can go in and cannot come out. Then this will become a time critical issue and must be dealt with immediately by basically puncturing the pleural cavity and making the tension into an open pneumothorax. Now, what will happen with this? This lung will collapse. And when the lung collapses, number one, it acts like an ambu bag for the normal lung. That means the normal lung will suck in air from the affected lung in inspiration and blow in air into the affected lung in expiration. Thus, the outside air will not be able to come, and this is impede ventilation. The second thing that will happen is that the vascular resistance in the collapsed lung is far lesser. Therefore, the entire right-sided unoxygenated blood output would pass through the collapsed lung and without getting oxygenated will return to the heart. Therefore, this is perfusion, ventilation, dissociation. The collapsed lung is not ventilated but fully perfused. And the normal lung has all the air but no blood. So this is called as the perfusion, ventilation, dissociation. And this air movement by the ambu-back phenomenon is called as the penduloft or the pendular air movement, as it's impeding ventilation. The, then in the third part, we have tried to explain the paradoxical movement of the flail chest segment. The flail chest segment, a segment of the chest, would be sucked in during inspiration and will be blown out during expiration, causing it to move paradoxically. So this paradoxical movement will cause less pressure changes on the affected side as compared to the normal side. So less negative pressure in inspiration will make air move from the affected to the normal side, and less positive pressure in expiration will make air move from the normal to the affected side in a pendular fashion, causing impediment of the ventilation. So these are the three things that will happen with either the collapsed lung or with a flail chest segment, and therefore collapsed lung by an intrapleural space occupying lesion is dealt with by intercostal drainage, and flail chest segment is treated by immediate stabilization. Both are emergency conditions and pathologies of perfusion, ventilation, and diffusion on which our life depends. After the heart and the lung, we pass on to the mediastinum. That means between the lung and behind the heart. Mediastinum passes the esophagus. So let us see what is the function of the esophagus. Food is chewed by the opening of the jaw, lateral pterygoid, closing by temporalis, and medial and lateral movement of the teeth over the upper jaw by the masseter and the medial pterygoid muscles. So the upper jaw is moving against the fixed teeth in the upper jaw. The lower jaw is moving, the upper jaw is fixed. The tongue is moving the food out from between the teeth into the vestibule, that is the space between the cheek and the teeth. And the buccinator in the cheek is moving the food back from the vestibule into the mouth. The parotid opening into the vestibule and the submandibular and sublingual opening into the mouth are mixing the saliva into this food and converting it into a bolus. Now this is the process of mastication. The tongue pushing against the palate squeezes the bolus over the epiglottis, and the epiglottis starts tilting backwards, covering the larynx. The root of the epiglottis is raised by the rising thyroid cartilage to which it is attached. The thyroid cartilage is pulled up by the stylopharyngeus muscle, and the stylopharyngeus muscle is supplied by the glossopharyngeal nerve, which again winds round the stylopharyngeus muscle, like the phrenic nerve winds round the serratus and the scalenus anterior. So this shuts the epiglottis over the larynx, and no food can go into the larynx. The palate, the soft palate, will rise up and will close the nasopharynx against a ridge, which is called as the Passavant's ridge, which is created by the innermost fibers of the superior constrictor. Therefore, the bolus can neither go into the larynx nor into the nasopharynx, and goes into the laryngopharynx and passes through the cricopharyngeus and through the esophagus into the stomach. This whole process is called as deglutition. Now you observe the passage of the esophagus first. It is passing behind the aorta, behind the left main bronchus, and then through the esophageal hiatus into the stomach. The vagus nerve will accompany this esophagus. Now we'll study the abnormalities of this esophagus. So this is the superior constrictor, this is the cricopharyngeus, and the weak space between the two is called as the Killian's dehiscence. Through this Killian's dehiscence, you can see this protruded mucosa, which is called as the Killian's diverticulum. Now food, instead of going into the esophagus, will go into the Killian's diverticulum, which will become heavier and heavier and will come to lie somewhere here and will cause progressive dysphagia. If you take a barium swallow, you will see what is called as a tea kettle appearance. And this Killian's diverticulum must be excised and the Killian's dehiscence must be closed to treat this condition. The second condition is that since trachea and esophagus develop from the same tube, sometimes there is an opening between the trachea and the esophagus called as the tracheoesophageal fistula. And this can cause aspiration, that means coughing, and pneumonia in a premature neonate, because when you feed the milk will actually go into the trachea and the lungs. The second thing is, what are the abnormalities of the lower end of the esophagus? The congenital one is called as achalasia cardia, where the peristalsis fails in the lower segment. And if you take a barium swallow, you will get what is called as a parrot beak appearance. And in the neonate, whatever he takes as milk, he vomits out immediately. So there's a severe dysphagia and parrot beak appearance, and you will have to resect this segment and anastomose the esophagus with the stomach to treat it. Till then, you will have to put in a rice tube and feed the child. So the second is that if the esophageal hiatus cannot close properly, then stomach acid will go into the lower part of the esophagus, causing gastroesophageal reflux disease. So the third thing is that if there's the failure of the esophageal hiatus, then the part of the stomach can herniate through the diaphragm, and that is called as the hiatal hernia. Then in cancer in varicose veins in the lower end of esophagus, because of connection of the portal and the cable system here, in cirrhosis of liver, you will find that there is worm-like appearance in the barium swallow, and these veins can bleed, causing severe hematemesis. You treat them by coagulating the distended veins through endoscopy. The fourth thing is that if there's a cancer of the lower end of the esophagus, you'll find rat tail appearance in the lower end of esophagus. You will have to resect or bypass the obstruction and treat the cancer by radiotherapy or chemotherapy. So these are the conditions of the esophagus which we must remember. Here you see these azygos system of veins draining the intercostals, but they drain into the superior and the inferior vena cava. The right and the left side is connected by the hemiazygos veins, and the left side is connected from the renal vein and the right side from the inferior vena cava, both of which also collect blood from the abdominal wall through the lumbar veins. So this is the azygos system of veins, and in this you have the cisterna chyli in the abdomen, then passes the thoracic duct, and this duct goes up to T6, then from the right to the left side goes through the thoracic inlet, curves around, passes behind in front of the scalenus anterior, and turns down and meets the subclavian vein of the left side. So this is the thoracic duct and the azygos system of veins. Now here are the nerves of the thorax. the parasympathetic and the sympathetic nerves. The sympathetic chain lies in the paravertebral space. It gives rami communicants to the intercostals, and it also gives branches to the uh, heart directly. And here you see the specific branches to these organs coming out of the whole of the sympathetic trunk. Besides the sympathetic trunk is the vagus nerve, which goes with the esophagus, and the phrenic nerve, which passes between the pulmonary artery and the aorta above the heart and supplies the diaphragm. So this is what you see in the nervous system of the chest wall.